Okay, well, let's go ahead and get started and see where it takes us. So let's just start at the beginning with the transport environment. And let's go ahead and just review the gas laws real quick. All right, so let's start at Dalton's law. What does Dalton's law tell us?
All the different pressures of each gas.
Good, so your pressure final or total equals the sum of all the individual pressures, right? P1 plus P2 plus P3, right? If you're talking about oxygen, CO2, and nitrogen with our atmosphere. And all the individual sums of the individual pressures would equal the sum of the individual pressures equals the total. Okay, cool. Let's talk about Charles' law. What does Charles' law tell us?
The volume is directly related to the temperature.
Good. So volume is directly proportional. So volume is directly proportional to temperature. Remember, most of these gas laws, you're looking at three variables: volume, pressure, and temperature, and then you hold one of those three constant and look at the other two. All right. So that is to say, when temperature increases, volume will increase, and when temperature decreases, volume will decrease. Easy enough. What about Gay-Lussac's law?
Similar to Charles, except that he holds volume constant.
Good.
Pressure increases with
So,
temperature.
perfect. So instead of volume and temperature, we're looking at pressure and temperature, and it's the same relationship, right? As temperature increases, pressure increases. Temperature decreases, pressure decreases. Good. What about Boyle's law?
When you hold temperature constant, pressure decreases if temperature, or volume increases, excuse me.
So, yeah, so Boyle's law, what we do is we hold temperature constant and we look at volume versus pressure. Now, the relationship is not, there is not a direct relationship, right? Rather, it is inverted, yeah. So that is to say that a decrease in pressure will equal an increase in volume, right? And then an increase in pressure will equal a decrease in volume. Okie dokie, let's talk about Henry's law.
The gas dissolved in the liquid will try to pull out the pressure that's around it.
Perfect. So if I have a container that has some liquid and I have a pressure of a gas dissolved in that, that pressure is proportional to the pressure of the gas that liquid's contained in, the pressure of the gas of the environment around it. And that's why if you are, say, a scuba diver and you go underwater, right, the pressure around you increases, which means the pressure of gas dissolved in your body will increase. And then if you were to suddenly go up to surface, the pressure around you would decrease suddenly, which would mean that the amount of gas dissolved in your blood would have to decrease, right? The pressure would decrease, and then that gas would want to leave your body, but it would have to go through membranes and get out of compartments, and then through other gas laws like Boyle's law, it can form little bubbles and be very, very problematic. Okay. Oh, Graham's law. What is Graham's law? What does that tell us? That's Graham's law of effusion. Say I have a container of a gas here, and then I have another container over here. All right. And let's say that the pressure of the gas in this container is 10 millimeters of mercury, and the pressure of the gas mixture here is 100 millimeters of mercury. What direction is the gas going to move?
To the lower pressure.
Yeah, so it's going to move from this container to this container. It's going to want to move through this little passage here. You guys cool? So I've set that up. So here I have gas. I have hydrogen gas, and it has a density, or it's got a mass of 2 grams per mole. And then I have helium, which is about 4 grams per mole. Okay, so which of these 2 gases is going to move or effuse fastest through that?
Hydrogen,
Why the hydrogen?
because it's less dense, it's easier to move, just like heliox.
Perfect. Less dense, effuses faster, and a perfect example of Graham's law would be using special gas mixtures and obstructive pathology like heliox. And so with heliox, what we do is we replace, typically you breathe nitrogen, right, N2 and O2. Those are the 2 major gases in our atmosphere. We know that nitrogen's a lot more massive than helium, so if you can replace that nitrogen with helium, that gas mixture will effuse a lot more efficiently into the lungs. Cool. Ideal gas law. What's the ideal gas law? It combines all 3 concepts. Good. So PV, pressure times volume, equals the number of moles of gas that we're dealing with times the gas Boltzmann's constant, and RT. So pressure times volume equals nRT. So basically N and R can be looked at as constants. So pressure times volume is proportional to temperature, is a super simple way of looking at the ideal gas law. Okay, you guys cool with that? Let's move to some regulatory stuff. So what are the 2 major regulatory frameworks that air medical transport operates under, or air transport in general operates under? Yeah, so FAR, Federal Aviation Regulations, Part 91 and 135. And what are the fundamental differences between 91 and 135?
135 has a paying passenger calling someone for compensation.
Good.
91 doesn't.
So basically you're dealing with people. You're dealing with people, like an air taxi, if you want to look at it that way. And Part 91 is more luggage, yeah. And how does that affect us? Well, that affects us because when we have a patient on board, we have to fly under 135, right? It is conceivable that you could work for a company that when you respond to the scene, you would respond Part 91, right? And then when you have the patient, you would then transition under 135. So aside from that, what are some other differences that we see with 91 versus 135?
135 has
More stringent weather requirements for Part 135. Perfect. Okie dokie. What are some of the major stressors of flight?
Fatigue.
Good. Fatigue. I think there are 8 of them, right? Good. Noise. Vibration. Good. Good. So pressure changes. Good. Temperature changes. I think there's, what, 1 or 2 more?
Humidity. Decrease humidity.
Is that right?
Yeah.
Good. Yeah, so decrease in humidity. And then there are factors that can modify those, and these are the depth, So what are the factors that compound the stressors of flight? So D is, yep, so T is tobacco, is alcohol, good.
H is exhaustion.
Hypoglycemia, good. E is exhaustion. Drugs. Good. All right. Cool. Let's see. Let's talk about the atmosphere. What are the major layers of the atmosphere? So here we have our planet. We've got a layer here, a layer around it here, and then an outer layer here. So what's the layer that's closest? Troposphere. And then out from there. And then the outermost layer, the thermosphere. And basically you're looking at the space equivalent zone there. And are you guys okay with your different zones? So you've got your physiologic zone. And that goes up to what, to about 9 or 10,000 feet, right? And this is basically the zone where you have more or less normal physiology occurring. And then you have the physiological deficient zone, which is what, 10,000 to 15 or so, right? Where you can function to some extent, but you're going to have deficiencies. And then you have what? Okay. We also have the outermost, which is kind of your space equivalent zone. And the only way to survive in that zone, your space equivalent zone, is what? Good. A pressure. So you actually have to be in a pressurized, some sort of pressurized cabin or pressurized suit. You can't compensate by just giving supplemental oxygen here. Okie dokie. So that looks good. You guys okay there?
Mesosphere, that's in between the stratosphere and
The
right?
thermosphere, right?
Yeah.
The mesosphere. Yeah. So right in here is where the, cool. All right. I think we're good to go there. Some general considerations for an LZ. What do we like our LZs to be? 100 by 100, good. 100 by 100. Have to have constant communication. All right.
15.
Huh?
Every 15 minutes.
Well, yeah, so when we talk about during the flight, so when we land, you have to have constant communication with people on the ground when you land, particularly at night. Let's talk about the regulations for safety while flying. So you need to have contact with your comm center every 15 minutes, right?
By air, 45 by ground.
By air, and 45 minutes by ground. If you miss this, what is that called?
15 minutes after you miss it.
So 15 minutes after you miss, or 45 minutes after you miss your last check-in, what needs to be activated?
Incident issue. Yeah.
Starts with a P.
Post.
Post-accident incident plan. Yeah, PAIP. That's a requirement for transport companies to have a PAIP in place. Good. We know that a lot of contemporary services, I don't want to say get around this, but what they do is they have like flight following, right? They have GPS flight following, so it's continuous tracking, so the crews are not having to call in every 15 or call in every 45 minutes. Cool, you guys go with that? Okie dokie. So, any other questions about any of that stuff there? I think we hit a lot of the major major points. Let's go ahead and move over to, let's talk about hemodynamics, since that's a new area, it's a big area. All right, so hemodynamics. So the way I look at hemodynamics is you want to think of the circulatory system. See if I can draw this here. So I'm going to draw my heart. And then I'm going to draw my lung here. All right, and then I'll draw the left side of the heart. And then I have got my peripheral. There we go. Okay, there we go. And then I'll just label these. So this is the right atrium, the right ventricle, the lungs, the left atrium, the left ventricle. Okay, so remember we talked about driving pressure? And for fluid to move, if I want a fluid to move in a certain direction, I have to have a pressure difference, right? So the pressure needs to be higher over here and lower over here. And that difference between the lower and higher pressures is known as the delta P, the driving pressure. So the pressure on the right side of the heart is going to be low or high? Low. And then the pressure on the left side is high. And that's going to cause a driving pressure that's going to push the blood in this direction, like so. And anything that affects these pressures is going to increase or decrease that driving pressure, and increase or decrease perfusion through this system. So that's the kind of the fundamental way of looking at the circulatory system. Is it's just basic pumping, basic circular pumping mechanism. Okay, so let's now talk about the different modalities. So what are some of the major modalities for hemodynamic monitoring? The major procedures that can be done. Okay, so you can go big or go home, right, with your Swan-Ganz or your pulmonary artery catheter. What else? A central line. And your art line. Yeah, these are the major ones. There's also intracranial monitoring, which is not something that you have to know in any sort of detail. You do have to know what your normal ICP is and how we calculate ICP, and that's just or calculate cerebral perfusion pressure, excuse me, and that's just mean arterial less your ICP. And if you were to run into that, they would just give you those values. They'd tell you what the ICP was. They'd give you a blood pressure, more than likely, and then you'd have to calculate a mean arterial based off your blood pressure. And what is the standard formula for mean arterial pressure calculation? Systolic plus 2 times the diastolic divided by 3, yeah. Or you could multiply by 1/3 as well. That's the same thing as dividing by 3. All right, good. And what's your normal mean arterial? 80 to 100, 70 to 100, right in there. Yeah. I think, what did they go with, 70 or 80? I think 70, right? Yeah. 70 to 100 millimeters of mercury is your normal mean arterial. Okay, cool. So let's start with the central line. And where do I place a central line? Well, it could be a subclavian, yeah. Yeah, so I place it in a large vein, and then ultimately a central line will sit right above the right atrium. And what parameter am I typically monitoring with a central line? Yeah, but what value? What concept am I looking at? Yeah, I'm looking at the CVP. And what is a normal CVP? Good, 2 to 6 millimeters of mercury. And this tells me something about the preload, for sure. All right. And it also tells me about how well the right ventricle is functioning, right? And possibly it might tell me some indirect information about the left side of the heart. Because if you have backup on the left side of the heart, right, that backup can be translated to the right side of the heart. So in general, a very low CVP tells us what? Okay, so it could either be a fluid volume status, could be a volume problem, or it could also be a problem with volume or a container problem as well. Yeah, and what value, we don't get this from the central line, but it since it's related, what concept tells us about, or what number can we monitor to tell us something about how dilated or constricted our vasculature may be? Yeah, the systemic vascular resistance. And what is a normal SVR?
800 to 1200 times.
Good. So if you had a normal, or well, let's say you had an elevated systemic vascular resistance and a low CVP, what would that point to?
Vasodilation.
Would it? So if your SVR, your systemic vascular resistance, is elevated and your CVP is low, what would that point to? Yeah, that point to a volume problem, right? Does that make sense? You're not getting good preload back to the heart, so the CVP is low, but your vessels are constricted. Your SVR is high, right? So, you know, you're going to need to be able to put these concepts together and make these connections with hemodynamics. So does that make sense why that would be a volume problem? Let's say, however, that your SVR is low and your CVP is low. It could be a combination of both, or it could be some sort of vasodilation, right? So you're looking at adding distributive shock in there as well, right? Is this somebody who's septic? Is this someone who's in anaphylaxis? Something on the lines of that. Okay, good. What does an elevated CVP tell us? Hypervolemia. Okay, hypervolemia is a big one. So fluid overload, absolutely. What else? Huh? It might tell us. Yeah, it's gonna look at the right side of the heart, right? So the things you want to be thinking about with an elevated CVP are, do I have the right side of my heart failing? All right. Or am I hypervolemic? Yeah, those are the two biggies. Okay, there's also a modality that we can place over here, all right, in the large artery, and that's known as the art line. And what is the big thing that we measure with the art line? Yeah, and it is a real-time blood pressure, right? It is a beat-by-beat blood pressure, and we can monitor the mean arterial pressure with that as well. Some other reasons that we'd want to put an art line in somebody would be to draw blood gases, right? Like the patient that had severe ARDS, and somebody asked, well, why isn't there an art line in? Why isn't there, right? That probably would have been a good thing, because they're doing, at a minimum, they're doing daily blood gases on this patient. They could have some reasons, right? They could have tried, and he had significant peripheral vascular disease, but they just didn't do it in this case. So, all right. And then finally, we have our pulmonary artery catheters, Swan-Ganz, whatever you want to call it. Let me select a different color. And this is inserted like a central line, but ultimately, where does it sit? It sits in the lung, right? Or in the pulmonary artery. And what values can we monitor there? Good. So you can see your CVP while you're inserting it. Good. What else? Well,
Ventricular pressure as you go through.
good. So you get your right atrial pressure, right? Your right ventricular pressure, your pulmonary artery pressure, and then what can you do?
When you wedge it, you can indirectly look at the left side of the heart.
Good. So you can get, so all of these here kind of look at all sorts of stuff, right? Preload, afterload, in the heart, in the lungs. But when you inflate the distal balloon and you get your pulmonary artery wedge pressure, right, you cut out all of the right-sided interference and you're looking at the left side of the heart. So what are, we know at the CVP, what's your normal right atrial / right ventricular pressure value, since they're pretty close? What are you looking at there? You sure?
I need to 30 for right ventricle.
20 to 30 what?
Millimeters of mercury.
What though?
Systolic.
Good, yeah. So 20 to 30. Now, in the right atrium, you will not get a systolic and diastolic, right? But in the right ventricle, you should. But 20 to 30 systolic is more or less where you want to shoot. How about the pulmonary artery pressure? What's the normal pulmonary artery pressure? Good. So basically, it should be about your right ventricular pressure. And then your pulmonary wedge pressure is
4 to 12.
good, yeah, 4 to 12. All right? So the wedge is a good way of determining, of finding out what where our problem is, right? Does that make sense? Because if your pulmonary artery pressure is elevated, your CVP is elevated, your right ventricular pressure is elevated, right? Well, that could be a right-sided heart problem. It could be a left-sided heart problem, right? There could be some other problems. But when you wedge, so let's say you wedge, and your wedge pressure is normal.
It's gonna be the right side.
There we go. Then you can automatically say, oh, this is not a left-sided problem anymore, is it? It's a right-sided problem. But let's say that you wedge, and your wedge pressure is elevated. That points more to a left-sided, okay? Let's say that your pulmonary artery pressure is elevated, and you wedge, but it's normal. So you have a high pulmonary artery pressure,
High pulmonary pressures.
good. Pulmonary artery hypertension, right? Yep. Okay, you guys cool with that? All right. And then there's one other thing that we can monitor with the pulmonary artery catheter. Yeah, what does that look at though?
Cardiac output.
Yeah, the cardiac output. All right. And then from the cardiac output, as long as we know what size of patient we're dealing with, we can get the cardiac index, right? Which takes cardiac output and body surface area into consideration. And normal CI is just half your cardiac, right?
2.5 to
Yeah, 2 to 4 basically, or 2.5 to 4, and then 4 to 8 for cardiac output. The other thing, and we typically don't get this through invasive lines, but we can get this through looking at an ultrasound, specifically the left ventricle, and we can get what? The left ventricular ejection fraction, right? That's the percentage of blood volume that gets pumped out of that left ventricle. What is a normal ejection fraction?
greater than 70%.
I think there's a range. It's like 50-something to somewhere in that neighborhood. Is that right? I want you guys to reference specifically what UMBC says, though, because everybody has their own slightly different range. What do they have to say about it? Nothing?
Not in the study guide,
Okay.
but the book's written by UMBC.
Huh?
The book's written by UMBC, so it can't be.
Yeah, I mean, it's gonna be a rough. Yeah, it's generally a range though, and I'll give you a hint. You'd never want to say it's greater than something, because 100% ejection fraction is not normal. That you would not want to see that at all. That's very, very, very unusual.
Less than 40 is bad, you know that.
Yeah, so less than 40 is definitely a heart failure situation.
55%?
Yep, it is in the 50s. The range should start somewhere in the 50s, and I just want to make sure that we have the right range, quote unquote, because everybody can have a slightly different take on that. I believe, but for the sake of just pushing the review forward, I believe it's somewhere in the neighborhood of like 55 to 85% or something on the lines of that. But I'll leave it to you guys to go back through your chapter reviews and that to verify that. Okay, what I'm gonna do now is I just want to give you guys some scenarios real quick. All right, so let's go with CVP, right ventricular pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, or pulmonary artery occlusive pressure, or whatever, cardiac index. All right. So let's say that we have a CVP of 10. Okay, what's the likely cause of these values? And I'm not giving you any history, I'm just giving you just straight up hemodynamic values. What major problems would you? Maybe.
Blood pressure is 42. So it's high all the way to your wedge pressure.
Uh-huh. So
Cardiac index as well.
fluid overload might be one thing. What is the other major thing you need to be?
Not a lot of cardiac output, because cardiac output by the body surface is low too.
Right. So what are you thinking here? Yeah, this is a left ventricular failure. Yeah. Yeah, good. Let me give you. What do you think here?
It's a blotting problem, the heart's
Good.
slowing down.
Perfect, yeah. Your CVP is low, right? So your preload is low, and then everything else is low, right? Yeah, so that's definitely more than likely a volume problem. Let me give you guys this here.
Chris, the normal ejection fraction is 55 to 75%.
55 to 70. I think it said 80, right? Yeah, 55 to 75. And then cardiac index. All right. We'll do one more here. Let me give you guys these values. Where's the problem at?
Pulmonary hypertension.
Perfect, right? So the pulmonary artery pressure is elevated, but the pulmonary capillary wedge pressure is normal. That is a classic pulmonary hypertension. And then you've got a good cardiac index, right? So you know the left ventricle is working just fine. Good. All right, so let's move into talking about 12 lead. I hope you guys are okay here. A couple of you choked in the cath lab, though. Huh? Yeah. You didn't choke?
We were seeing, we thought you didn't know, we didn't want to give you the answer.
Oh.
We were wrong, we were just tricking you.
Oh, I see how it is, yeah. Yeah, all right, so, you look at your 12 lead. So leads 2, 3, AVF. What coronary artery are we primarily looking at here? The RCA. What areas of the heart are we looking at? Inferior wall of the left ventricle, posterior wall. What else? Well, primarily the right, not the inferior wall of the right ventricle, but pretty much the entire right ventricle, right? And then special structures, right? Your SA node. All right. Let's see here. V1 through V4 is what coronary artery primarily? Good. So the left anterior descending branch of the left coronary artery, the LCA, because remember the LCA bifurcates into the LAD and the circumflex. What major structures do we have here? Septum, good. The anterior wall of what? Of the left ventricle. Good, yeah, widowmaker there. And then we have V5, V6, 1, AVL. That's the circumflex. And that's the lateral of what? Of the left ventricle and part of the posterior wall. Okay, good. You guys okay with the difference between ST elevation, ST depression, pathological Q waves, all that good stuff, and localizing changes, because you're going to get 12 leads. You get 12 leads. Okie dokie. Let's see here. What else do I want to say? I think we're good there. Cardiac enzymes. Okay, just make sure you know your major cardiac enzymes as well. Again, with most of the labs, they're going to tell you whether they're high or low. ABGs, you guys good on ABGs? Should be. We've done a bunch of them, so I won't spend a whole lot of time going over arterial blood gases. But let's talk about mechanical ventilation real quick. Okay, so let's talk about our major types of ventilation. What are the major types that we have? Not modes. I'm talking types. Yeah, so our limits, right? So you have volume control ventilation. What else? Pressure control ventilation, and then you have hybrids. Hybrids where you have combinations of both volume and pressure. Yeah, the mode that you guys have dealt with the most which is PRVC, pressure regulated volume control. In some ventilators, it's known as volume control plus. So basically, you try to target a tidal volume, and then you have pressure pop-off limits that you set, and so it kind of is a combination between volume and pressure. It delivers the breath in a ramp, it's generally in a ramp format, like pressure control as well. Okay, and then we have modes. Okay, so you have your classic CMV, right? Controlled mechanical ventilation. And classically, CMV is just a complete lockout, right? It's a breath, it's a volume, that's all you get. And then you have assist control, where if you trigger the ventilator, it delivers whatever the preset breath is. And then you have SIMV, which is synchronized or mandatory or mechanical ventilation, and that just allows the patient to take spontaneous breaths on top of the mandatory breaths. And then we also have spontaneous modes. All right. So what are some spontaneous modes? Good. CPAP. What else? BiPAP. Good. And one other. Spontaneous mode. Remember I said think of it as PEEP or CPAP, 1/2 CPAP.
Pressure support.
PSV, right? What is pressure support ventilation?
Gives them a little extra pressure on inspiration.
On inspiration only. Yeah, they're only getting pressure when they inhale. CPAP, you're getting that pressure all the time. Okay, and then we can use these, okay, to, in some cases, to support some of the other modes. For example, what could I do with SIMV?
You can add pressure support.
You can add pressure support, SIMV plus pressure support, right, to assist those spontaneous breaths, to help overcome some of the resistance that patient has. Good. When we add CPAP to somebody who is on mechanical ventilation, so they're receiving mandatory ventilation and they have CPAP, what do we call CPAP in that case? What does it become? PEEP, yeah. There is really no physiological difference between PEEP and CPAP. It's the same thing. It's pressure that's always there. But when you have somebody on some sort of mandatory, okay, they're receiving mandatory ventilation, you're adding that CPAP to augment that. We call that PEEP in that case. Okay, let's see, what are some other settings? You, of course, are aware of your frequency or respiratory rate, the FiO2. We like to keep the FiO2 under what?
60.
Yeah, 60% and under if we can. We've got the flow, right? That's how quickly the breath is delivered. And what patients may require high flows? Not necessarily, no.
Obstructive.
Yes. Obstructive pathology, right? Because what is increased flow? What is increased flow going to do to your I time? It's going to decrease your I time, which will do what to your E time?
Give it a longer E time.
Yes, right? So increasing flow is very good when we want to allow for prolonged expiratory phases. And in fact, with ARDS patients, there are specialty things that we can do, right? Like bilevel ventilation and APRV, where the flows are very low. Why? Because the I times are longer than the E times. Remember, those are modified inverse ratio ventilatory strategies for patients with ARDS. Okay, obviously that leads to our IDE ratio, and we want to have a longer IDE ratio with obstructive pathology, generally speaking. Some other things, you know what the peak inspiratory pressure is? and the plateau pressure, the P plat. All right. And the difference between the PIP and the P plat tells us something about the airway resistance. All right. So if there's a large difference, that is the PIP is really high and the P plat is far below that, that tells us that we're dealing with some sort of obstructive pathology, something that's increasing airway resistance. When the PIP and the P plat go up together at the same time, that's more of a lung compliance problem, right? A low compliance like pneumonia or ARDS or circumferential chest wall burns or abdominal compartment syndrome, yada, yada, yada. Okay. So there are major things when it comes to ventilatory management. The major things that we look at are correcting oxygenation problems and ventilation problems, right? So if someone's not oxygenating well, what are some things we can do to improve oxygenation? Good, add PEEP. PEEP is one of the major ways that we can do that. Or we can increase the FiO2. But adding PEEP is very helpful, and we can do that without risking oxygen toxicity, but PEEP does have its own side effects, right? Anytime you put positive pressure in the chest, you're going to decrease preload, which is going to decrease cardiac output. So you got to monitor your hemodynamics real closely with PEEP. With ventilation, how do we change ventilation?
Increase tidal volume,
Good, so you can increase your tidal volume or
increase your rate.
increase or decrease the rate depending on what's going on. Excellent. And in pressure control ventilation, can you set a tidal volume?
Get pressure.
Yeah, in pressure control, pure pressure control. I'm not talking about hybrid, PRVC or. Yeah, so you can't set a tidal volume. You set your PIP, right? And then you have to monitor what your exhale tidal volumes are, and then go up or down on the PIP. Whereas in volume control ventilation, you can't control the PIP, right? You can only control the volume, so you may have to go up or down on your volume to control your PIP. Okay, and then both of these go into a concept known as the VE, which is a minute ventilation, right? And generally, your minute ventilation is going to roughly equal your cardiac output, right? And that is a concept known as VQ, ventilation perfusion matching, right? And in general, it's about 0.8, 80%, right? And we know that you can have situations where you have more ventilation than perfusion, like a pulmonary embolism would be the classic example, right? Where you don't have perfusion of the lungs even though you can ventilate the lungs. And then in some cases you can have more perfusion than ventilation, for example, atelectasis. If you have lots of atelectasis, you're getting blood through the lungs, but you're not able to ventilate them. Does that make sense? Huh? Which can lead to shunting, yeah. So shunting shunting I look at is a type of VQ mismatch. And shunting typically is where blood goes from the right side of the heart to the left side of the heart without doing what? Without going through the lungs or without becoming oxygenated. And then in some cases, if you're talking like congenital heart defects, you can actually get what's known as a left to right shunt. But that is more of a congenital heart defect thing and not like a standard thing we talk about in pulmonology. Okie dokie, you guys good there? You guys good with some of the medications that you can use to help make patients more comfortable? Do we like to paralyze our intubated patients? Yeah, generally we only want to paralyze them during the RSI, and then we want them unparalyzed or minimally paralyzed, right? Because we want to be able to assess them. We want their muscles to be able to shiver, to generate heat. We want them to interact with the ventilator. There's really good reasons not to just keep them paralyzed for the whole transport. And in general, if you have a problem, go to the patient first, right? Assess the patient first. make sure that the ventilator, whatever your settings are, make sure the settings are good for the patient. So before you move on to bombing them with drugs, make sure that you have appropriate ventilator settings, right? The flow is high enough. They're getting the volume that they need. Make sure those things are in place before you start hitting with midazolam and fentanyl and vecuronium and all that stuff there. Okay, good. So speaking of that, we'll talk about airway management. Are you guys generally okay with the concept of RSI? Not everybody is necessarily a candidate, right, for RSI, and there are like alternatives. If you have a predicted a difficult airway, you're not very confident, right, there are other alternatives, right? You have non-surgical options like nasal intubation. You have surgical options. You have your primary backup, which is always going to be BVM ventilation, right? Why do we RSI patients? Well, remember the three major things: inability to protect the airway, respiratory failure, and that could either be failure to oxygenate, failure to ventilate, or a combination of oxygenation and ventilation failure, and then the predicted clinical course. All right. What are the P's of RSI?
Pre-oxygenate.
Okay, so first, let's start at the beginning. So prepare, right? Good. All right, so what do you want? You want soda. You want your suction out. You want your oxygen good. You want your drugs pulled up. You want all your airways, a tube larger and smaller than you think you'll need, supraglottic airways. All right, good. So prepare. And part of that will include the lemon exam. All right, so lemon soda while you prepare. And the lemon exam is to look, right? Evaluate, and that's the 3-3-2 rule, right? 3 fingers, mouth opening. Good. 3 fingers on their jaw, and then 2 fingers on top of the thyroid at the thyromental distance. Good. All right, so that's evaluate. M is the Mallampati. To appropriately assess a Mallampati, you actually have to have the patient sitting up and able to talk to you to get the real deal. There are modified Mallampati scores that can be done in other patients. But there you go. All right. O, obstructions, obesity, and then N, neck mobility, right? Good. And then S, I like to throw S on the end of that, saturations, right? Okay, so we prepare and then we pre-oxygenate. And ideally, we like to pre-oxygenate how many minutes before the RSI? 3 minutes before we give the paralytic. There are alternatives though, right? If we can have our patient take 8 vital capacity breaths, all right, good deal. Then what? We prepare, we pre-oxygenate.
Pre-medicate.
And I'm going to throw position in there, right? Properly position the patient, the help position, all right? And then what? Pre-meds? Pre-med. And this is sort of optional, and there's some controversy here, but in general, what are your pre-meds? Those are your load mnemonic. So lidocaine, opioids, atropine, and defasciculating if you're using a depolarizing, yeah, like succinylcholine. Good. All right. And then what? Paralyze, but induce first, right? So you give your induction agent, whatever that may be, and we've talked about them, right? They all have their pros and cons, right? Propofol, midazolam, ketamine, etomidate, okay, all your different induction agents. Give your induction agent, then give your paralytic, all right? And then what? Pass the tube and prove it's in where it needs to be. And then finally, post-intubation care. You guys go with that? All right, that's That's RSI in a real big nutshell there. Okie dokie, let's see here, moving right along. So at this point, we've covered a lot of the specialty stuff. Are there any specific areas that you guys wanted to hit up? I talked a little bit about the transport environment and the physiology, because a lot of that's new. We talked about hemodynamics, we talked about ventilator management, we talked a little bit about RSI. A lot of the other material is sort of fundamental or sort of foundational paramedic stuff. You know, a lot of the medical and trauma stuff. See, you guys are good on ABGs. You're good on the anion gap. And that's primarily metabolic, right? Metabolic acidosis, non-anion gap versus anion gap. There's going to be some pharmacology on the exam, but they don't tend to focus on specific doses so much as what the drug does, why you give it, complications, contraindications, those kinds of things. Labs, how are you guys on labs? Yeah, so you don't want to focus on memorizing specific values, but are you okay with what, if a certain lab is elevated or a certain lab is low, what that might mean? More or less. So let's just, we'll go over a few here. All right, so your white blood count. An elevated white blood count is known as leukocytosis. Low is known as leukopenia, right? What causes leukocytosis? Infection, trauma. What causes it to be low? Immunosuppression, right? Cancers, immunosuppressive therapies, chemotherapy. Cancer can also cause it to be elevated, right? Leukemias. And then if it is elevated, you need to do a manual differential, right? Specifically looking at the neutrophils, right? The banded and segmented neutrophils, or immature or mature neutrophils. Hemoglobin and hematocrit, that tells us something about our oxygen carrying capacity, right? And a very low hemoglobin hematocrit indicates what problem? General problem. Anemia, good. And then there are all types of anemia, right? There's macrocytic, microcytic, sickle cell, right? What kinds of things can cause anemia? Well, blood loss, right? Iron deficiency, folic acid deficiency, okay, some common causes. And then your platelet count. What's an elevated hemoglobin hematocrit? So anemia is low, but what's elevated? Polycythemia, good, right? And there are some things that can cause, probably the most common cause of polycythemia is chronic exposure to hypoxia, either through lung disease or in a hypoxic environment. Good. And then there's polycythemia vera, which is a pathological condition where you just create, platelet count. Elevated platelet count is thrombocytosis, right? And remember, in dealing with cells, cytosis always means elevated pretty much. And then penia, thrombocytopenia, right, means a low platelet count. What are some things that can cause our platelet count to be low? Maybe. DIC is more of a clotting factor, but yeah, you could definitely lose platelets in DIC for sure. What's maybe a common, maybe like a medication that can cause it? Heparin, good. Heparin-induced HIT, heparin-induced thrombocytopenia, good. Okay, let's look at our blood chemistry here real quick. All right, so we know about the sodium. High sodium is hypernatremia, low sodium hyponatremia. Sodium tends to affect the brain, right? Hyponatremia tends to cause cerebral edema and seizures. Potassium, hyper and hypokalemia, that tends to be cardiac nature, tends to affect cardiac conduction. Chloride tends to go along with sodium, right? Hyper and hypochloremia. The venous CO2 is really, it's just bicarb, right? Really, that's what it's a measure of bicarb. But we know that 70% of your carbon dioxide is transported in the form of bicarbonate, so they kind of get around that by calling it CO2. BUN and creatinine, what do these look at? Renal function. They're elevated, indicates dehydration, kidney injury. And then glucose, you guys are good with your glucose. What looks at the liver? AST, ALT, what else? Bilirubin, anything else? It's a major cause of death from liver failure. They do, sort of, indirectly, possibly. Huh? Ammonia, right? NH3. Remember, one of the most common causes of death with liver failure is hepatic encephalopathy, which is often due to elevated ammonia levels. Good. Since we talked about them, your coag profiles, your PTT, your PT, your INR, your fibrin split products or fibrin degradation products, your D-dimer. All right. Which one of these looks primarily at heparin? Good, heparin. And then coumadin, PT and INR. Good. All right. Fibrin split products, elevated fibrin split degradation is classically seen in DIC. Elevated D-dimer is seen in situations where you're breaking down blood clots, right? PE would be one example, trauma, those kinds of things. Good. How about the pancreas? Good. The amylase, lipase. All right, well, remember the injury to the face can cause an elevation in your amylase because of the salivary. Good. Okay. It's lipase. Cardiac enzymes. So CKMB, myoglobin, and the troponin. Elevated myoglobin due to muscle injury is known as rhabdomyolysis. Good. All right. Okie dokie. I think we're good there. Calcium as well. You can have hypo and hypercalcemia. Calcium tends to affect neuromuscular function, particularly with hypocalcemia, where you get the Chavostics and the Trousseau sign. Good deal. Okay, I think we're good there. How about, do you guys need a quick break? We'll take a quick break and then we'll pick it back up with radiology.